പരിശുദ്ധനും നീതിമാനുമായ ഞങ്ങളുടെ സ്വർഗ്ഗസ്ഥ പിതാവേ, 2026 ഫെബ്രുവരി മാസത്തിലെ 1-ാമത്തെ വ്യാഴാഴ്ച ഞങ്ങൾക്ക് ഇതുപോലെ ഈ തിയേറ്ററിൽ കൂടുവാൻ തക്കൊണ്ട് ദൈവം സഹായിച്ചതോർത്ത് സ്തോത്രം. എല്ലാ വ്യാഴാഴ്ചയും പുതിയ കാര്യങ്ങൾ ഞങ്ങൾ കേൾക്കുകയും ഗ്രഹിക്കുകയും ചെയ്യുന്നത് പോലെ ഇന്ന് ഞങ്ങളോട് ഇടപെടണമേ, സംസാരിക്കണമേ. അത് അവതരിപ്പിക്കുന്ന ഡോക്ടർ ഷോണിന് വേണ്ടി പ്രാർത്ഥിക്കുന്നു. അവിടുത്തെ സാന്നിധ്യം കൂടെ ഇരിക്കണമേ. ഇന്ന് വന്നവർക്കൊക്കെ ഇന്നത്തെ ടോക്ക് ഇന്ന് ഞങ്ങൾ കേൾക്കുന്നത് കാണുന്നത് അതിന് അനുഗ്രഹമാക്കി തീരുവാൻ സഹായിക്കണമേ. പ്രാർത്ഥന കേട്ടതിനായി നന്ദി. ഞങ്ങൾക്ക് വേണ്ടി ജീവൻ വെടിഞ്ഞവനായ യേശു ക്രിസ്തുവിൻ്റെ നാമത്തിൽ അപേക്ഷിക്കുന്നു. ദയതോന്നി കേൾക്കുമാറാകണമേ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Thank you, Achin. So today I am very happy because Dr. Shone has taken up this responsibility, and you can see that the title is very aptly put, Dangerous Innocence. So this is kind of a provocative title for a class of drugs, that is steroids. We know that particularly in endocrinology, we know them as life-saving drugs. Whether it is treatment of congenital adrenal hyperplasia or adrenal insufficiency, they are essential medications. Yet there is a danger to this. So when we say steroids, sometimes we overlook certain things about steroids. So today we want to highlight this, that the difference between adrenal insufficiency or hypocortisolemia and what steroids can cause, the dangers of long metabolic complications. So the margin of error is actually razor thin. So to walk through the nuances of this delicate balance, I invite Dr. Shone. Over to you, Shone.
Thank you, ma'am. Good morning, all. Good morning, all. Kolla. So today I will be speaking about a dangerous innocent man. So with the photo of kidneys, Geosar is thinking I'm going to take a class on kidneys. Well, today I want to start my topic with this small quote from a famous English writer. The road to hell is paved with good intentions. Nothing. Sometimes when we try to do something good for anybody, not for a patient, maybe in our daily life or something, sometimes the result may not be what we expected. So this is nothing introduction, as everyone knows. So today I'm going to speak about adrenal gland. So as everyone knows, adrenal gland has two layers, the outer layer and the inner layer. And today I'm going to speak about steroids. So basically, the outer layer has how much layers? My colleagues? Paranjo? Three layers. So which layer produces cortisol? Yeah, zona fasciculata, the middle layer. So this is just a small short form to learn, just to remember. GFR, zona glomerulosa, zona fasciculata, and zona reticularis. So this is just a small classification based on their potency. So here you can see the low potent steroid is hydrocortisone, and a very high potency steroids are mainly dexamethasone and betamethasone. ഇതുവരെ വളരെ ശരിയല്ലേ? ഇതുവരെ വളരെ ശരിയാണ്. എന്നാൽ ഇപ്പം ശരിയാക്കി തരാം. Now we move on to a beautiful story. So this is a 56-year-old lady, a teacher, who is known for multiple comorbidities. She comes to her OPD. And she complains of body weight gain around 5 kgs. And she complains of having chubby faces, round faces. So നമ്മൾ പലരാണെങ്കിൽ വെയിറ്റ് കൂടാന്ന് പറഞ്ഞാൽ നമ്മൾ പറയും സ്വാഭാവികം. കഴിഞ്ഞ 2 ആഴ്ചയായിട്ട് ഭക്ഷണം പുറത്തുനിന്ന് നന്നായി കഴിക്കുന്നു, സ്ട്രെസ് ഈറ്റിംഗ്, ക്രേവിങ്സ്, പല കാര്യങ്ങൾ പറഞ്ഞ് നമ്മൾ അതങ്ങ് വിട്ടുകളയും. ബട്ട് ദിസ് ടീച്ചർ ഇസ് സോ കോൺഷ്യസ് ദാറ്റ് വെയിറ്റ് ഗെയിൻ കണ്ടു, 2 ആഴ്ചയ്ക്കുള്ളിൽ 5 കിലോ കൂടുന്നു, ഷീ ഈസ് ഗെറ്റിംഗ് പഫി. ഷീ കെയിം ടു അസ്. സോ നമ്മൾ ബ്ലഡ് ചെക്കപ്പ് ചെയ്തു. ബ്ലഡ് ചെക്കപ്പ് ചെയ്തപ്പോൾ വി സോ എ മൈൽഡ് ഹൈപ്പോനാട്രീമിയ ആൻഡ് വി സോ ചുമ്മാ കോർട്ടിസോളും ചെയ്തപ്പോൾ ദ കോർട്ടിസോൾ വാസ് ഫൗണ്ട് ടു ബി ലോ. വാല്യൂ കാണാമോ? ഇറ്റ് വാസ് ലെസ് ദാൻ 4 nanogram. So we did this short synactin test. സോ ഞങ്ങൾ എൻഡോക്രൈൻകാർക്ക് ഒരു പ്രശ്നമുണ്ട്. ഞങ്ങൾ ഈ ലോ ഹോർമോൺസ് കാണുമ്പോൾ അത് നമ്മൾ സ്റ്റിമുലേറ്റ് ചെയ്യാൻ നോക്കും. ഹൈ ഹോർമോൺസ് കാണുമ്പോൾ അത് സപ്രസ് ചെയ്യാനുള്ളൊരു ത്വര കൂടുതലാണ് ഞങ്ങൾക്ക്. സോ അങ്ങനെ ഞങ്ങൾ ഷോർട്ട് സിനാക്റ്റിൻ ടെസ്റ്റ് ചെയ്തു, ഓൾസോ നോൺ ആസ് ACTH സ്റ്റിമുലേഷൻ ടെസ്റ്റ്. സോ ഈ ടെസ്റ്റ് ചെയ്തപ്പോൾ the ATM cortisol was less than 4. അത് സ്റ്റിമുലേറ്റ് ചെയ്തപ്പോഴത്തേന് 38 വരെ വന്നു. പക്ഷെങ്കിൽ ഇറ്റ് വാസ് നോട്ട് ആസ് ഹൈ ആസ് വി എക്സ്പെക്റ്റഡ്, നോട്ട് above 180. So her adrenal glands were suppressed, was not stimulating as expected. A CECT abdomen was done, which showed normal adrenal glands. അപ്പോൾ അടുത്ത ഞങ്ങളുടെ ചിന്ത ഇങ്ങനെയാണ്, അഡ്രിനൽ ഗ്ലാൻസ് സ്റ്റിമുലേറ്റ് ആവുന്നില്ല, സ്റ്റിറോയിഡ്സിൻ്റെ ഹിസ്റ്ററി ഒന്നുമില്ല. ഞങ്ങളിങ്ങനെ ഇരിക്കുക ഡിപ്പാർട്ട്മെൻറ്റിൽ, ഞങ്ങൾ JRs ഇരിക്കുന്നു, CPമാരിയിരിക്കുന്നു, ഞങ്ങൾ എവിടെ ഹിസ്റ്ററി എടുത്താലും ഞങ്ങളിങ്ങനെ ഇരിക്കുക. അവസാനം ഞങ്ങളുടെ കൺസൾട്ടൻസ് വരണം. ഇന്നലെയും അങ്ങനെ ഒരു സംഭവം ഉണ്ടായി. സോ ഞങ്ങളുടെ പ്രിയപ്പെട്ട കൺസൾട്ടൻറ്റ് ഫിലിപ്പ് സാർ വന്നു, പേഷ്യൻറ്റുമായിട്ട് സംസാരിച്ച് അവസാനം ഒരു സാധനം പുറത്ത് വന്നു. സോ ദിസ് പേഷ്യൻറ്റ്, the actual cause was, this patient was on clobetasol propionate steroid cream as she had complaints of severe vaginal itching on and off for the past 1 year. And then സാറ് ഉത്തരം കണ്ടുപിടിച്ചു, ഡിപ്പാർട്ട്മെൻറ്റിൽ എല്ലാവരും കിട്ടി ഉത്തരം കിട്ടി. So what is the clinical relevance here? So basically, most of the times, we always expect oral steroids to be the villain, and we do not recognize the topical or inhaled steroids into this picture. The systemic absorption is frequently underestimated, and in such cases, the HP axis can occur silently, which results into adrenal crisis. So this is just a steroid equivalence table. In this you can see the equivalent, the prednisolone 5 mg. So any steroid equivalent to 5 mg prednisolone is given. So very commonly we see 5 mg prednisolone is equivalent to hydrocortisone 20 mg, which is also equivalent to 0.75 mg of dexamethasone. These are the common steroids which we see throughout our hospitals. So this is a second case study. In this case study, so this is a senior gentleman, 70-year-old man, known case of multiple comorbidities. So he comes to our OPD. He claims that after his meals, he can't concentrate on consulting the patients. ഒരു പേഷ്യൻറ്റ് കണ്ടുകൊണ്ടിരിക്കുമ്പം പെട്ടെന്ന് കോൺസെൻട്രേഷൻ പോകുന്നു, ക്ഷീണം വരുന്നു, തളർച്ച വരുന്നു. ആൻഡ് ചുമ്മാ ആസ് യൂഷ്വൽ നമുക്ക് അങ്ങനത്തെ ഒരു സിംറ്റം വരുമ്പോൾ നമ്മൾ ആദ്യം എന്ത് ചെക്ക് ചെയ്യും? നമ്മുടെ RBS ചെക്ക് ചെയ്യും. We checked our RBS, he checked his RBS, it was around 70-80. So we suspected for what? Reactive hypoglycemia. So we did 5R GTT test. We also did a plasma ACTH and ATM cortisol. It was found to be a bit low, but the stimulation did well. It went above the normal expected levels. And then we found to be having one more history in this. He was also a known case of chronic bronchial asthma, and he was on inhaler. He was on MDI budesonide, 200 mcg, 2 puff BD. Okay, so that is around 800 mcgs a day. And for the past many years, he is on this inhaler. Then we discussed with the pulmonologist, we reduced his dose, and then from our side, we started a low dose replacement prednisolone 5 mg therapy. So this was his GTT, and as we see on the 4th hour, there was a mild dip. It went up to 88. So now we see a little bit about inhaled corticosteroids. The epidemiology of inhaled corticosteroids. So high prevalence in asthma and COPD patients. Long-term use of these inhaled corticosteroids are very common. Potent topical steroids widely prescribed and are very easily accessible. So this is the GOLD 26 guidelines. So this highlights basically the common combinations of inhalers that we use, that we prescribe commonly. How common is adrenal insufficiency in patients with inhaled corticosteroids? So here we can see about 7% of prevalence is present in patients using inhaled steroids. And in about 30% of patients, we can see biochemical suppression. Patients using high dose or prolonged use of this inhaled steroids. The risk increases when the duration goes for more than 12 months. That is, for more than a year, when the patient continues using an inhaled steroid, the risk factor also increases. And clinically, it remains underdiagnosed. So these are some dose thresholds among the common inhalers that we see. Fluticasone propionate, that is in adults, that will be above giving 500 microgram a day. In children, it will be above 200 microgram a day. Then budesonide, more than 800 microgram a day. Just few minutes before, I just mentioned this inhaler. So that patient was on how much? How much? 800. So that is for many years. This dose threshold tells budesonide greater than 800 microgram a day. That patient was on many years. Factors increasing the risk of glucocorticoid-induced adrenal insufficiency. High daily doses given for more than 6 to 12 months, treatment with fluticasone propionate, concomitant use of oral glucocorticoids along with the inhalers. And in pediatrics, we can think of lower body mass index and higher compliance with treatment. Next are some topical steroids. When do we suspect an HPA axis suppression when using on topical steroids? When very potent steroids like the clobetasol propionate, as I mentioned before in a case, large body surface involvement, prolonged and continuous use like for more than 4 weeks, occlusive steroid dressings, or on thin skin. The dose thresholds in topical steroids, as we see, according to their potency, when they are classified, the class 1 is clobetasol propionate. Before, in the case we saw, clobetasol propionate, for how long was she using? For almost an year. Then the lowest potency one is hydrocortisone. Now the factors increasing the risk: long-term and frequent use of large amount of high potency glucocorticoids, prolonged use on inflamed skin or with impaired barrier, or for occlusive dressings, large body surface area, and then last is the cosmetic use. Cosmetic use is also an important factor, as many of us would not think of, or maybe just want to get fairer even more. But this is also a risk factor in cosmetic in the area where they mix steroids along with their, the mix-up they do. So this is also a risk factor. So this is a recent publication in the Endocrine Society that states anyone on equal to or more than 5 mg prednisolone for more than 4 weeks, that is almost continuously for a month or more, is on the risk of hypothalamus pituitary adrenal axis suppression. So, and this, and it also states about the tapering of steroid doses. And it also mentioned about the stress dosing. As we all know, we give stress dosing to every patient who was recently weaned off or maybe on low dose steroids. And this is a beautiful story. I guess some of you guys know the story. So this is a case from Bihar. So the story is called The Tale of Two Babies. The mother of these two babies wanted her children to be nutritious, very nutritious they wanted to be. So her mother, their mother gave them oral drops. Their children become became healthier and healthier. They become chubby. See how cute no they are. കണ്ടോ ഇപ്പോഴേ അവിടെ നിന്ന് കൊഞ്ചിക്കാൻ തുടങ്ങി ഫോട്ടോ കണ്ടപ്പോഴേ പിള്ളേരൊക്കെ കൊഞ്ചിക്കാൻ തുടങ്ങി. But there was a small problem in this. What she gave was oral drops of steroids. And it was given because she wanted her children to be nutritious. She wanted her children to be healthy. That was the reason why she gave oral steroids. So these are two studies done in the Bihar region. So these studies showed, in the first study, it showed that steroids contributed or had brought in the complications of cataract, recent onset diabetes after starting the steroids, hypertension, and osteoporotic fractures also were involved in this complication. Now the second study, I don't know how common, but why the reason for me also to introduce this, put this slide also is because you see this green graph, no? The misuse of steroids, this green graph. This green graph tells about prescribed by unlicensed practitioners. So I don't know, maybe some studies, give us something extra from the objectives that we do the study. So that was in Bihar, nothing common. We are in Kerala, no? High literacy. We are so well educated, no? So this is a study done in Kerala, in Tiruvalla region, the pharmacies. The study was done to know the sales rate of steroids in a day. And along with that, we also took one more objective, that was this. The pharmacist who's prescribing, not having the knowledge about its uses and not having knowledge about its adverse effects. Now, in hypercortisolism or any patient with adrenal axis suppression, now we usually find patients with patient coming up saying that this patient, he tells he has extreme fatigue. He just wants to lie down somewhere. He is not interested in going out and speaking. He's not interested in going out, doing his job. Or after his job, he just wants to come and lie down. He doesn't like doing household works. His loss of appetite, anorexia, nausea, fatigue, all these complaints he has, just like how you see in this video, this man, he has his morning bath, gets fresh, prays. He tells his wife, call me for lunch. He puts his shirt. We think he's going for his job, but he goes to sleep. The only thing, the main presentation in our OPD is fatigue. And they'll do an outside sodium report telling it's a low sodium. Now, what is the diagnostic algorithm for adrenal insufficiency? So, any patient coming up with this, we mainly do a sodium, potassium, ATM cortisol, and plasma ACTH. Now, we find anything suspected, like if we find a low sodium, what do we do next? We make them do a ATM cortisol. And if the ATM cortisol is found to be in the intermediate ranges, we do a short synactin test or an ACTH stimulation test. So these are some new guidelines done across. So these studies mainly tell that nowadays, instead of doing this short synactin test, it is better to do an ATM cortisol. A fresh morning sample of ATM cortisol is enough to suspect a patient with HP axis suppression. And any patient on steroids, we outside India, internationally, they give some wrist bracelet, just to caution them that in any case of stress period, any fever or anything else, they are supposed to be given a stress dosing of injection hydrocortisone. And this is a steroid alert card given from our department, from our hospital, to every patients who are on steroids. So it's time that I wind up. So the main key points. Steroids are life-saving hormones. Very true. In any case, in any critical cases or in any case, steroids are life-saving hormones. The indication, dose, and duration determine its safety. നല്ല കുട്ടിയുമാണ് ചീത്ത കുട്ടിയുമാണ്. So its indication, dose, and duration determine its safety. Hydrocortisone is the drug of stress dose choice in stress dosing because of its combined glucocorticoid and its mineralocorticoid activity. Long-term steroids like the dexamethasone or betamethasone, they have a higher risk in prolonged use. That leads to HP axis suppression. Abrupt withdrawal of chronic steroids can cause adrenal crisis. Mineralocorticoid activity worsens fluid overload. So another one, infections may be masked by steroids. Chronic steroid therapy requires preventive strategies. Every steroid prescriptions needs to have an tapering plan, and regular assessment is essential. We need to make sure that any patient on a steroid must be on our follow-up, must not lose a follow-up. That is, the patient should not continue taking 5 mg prednisolone, even though it is a low dose. Doesn't mean that the patient should continue taking it for more than 4 weeks, 2 months. It should not go on. So I would like to end with this small sentence, a phrase. The danger of steroids lies not in starting them, but in forgetting when and how to stop. എല്ലാവരും അടുത്തോ? കയ്യടിയൊക്കെ തുടങ്ങി. ഇപ്പം ഇവരുടെ മനസ്സിൽ എന്താണെന്നറിയോ? ഇതാ ഇപ്പം ഇവരുടെ മനസ്സിൽ. ഇനി നീ മിണ്ടരുത്, ഇന്നത്തെ കോട്ട കഴിഞ്ഞു. So, thank you so much. Thank you to my entire BCMCH family, I should say, including my mentors, my family, my team, my colleagues, their motivation for the past many days. Thank you so much. Thank you so much for everybody for hearing me. Thank you so much.
Thank you, Dr. Shone. So I'm really happy that Shone was daring to take up Quest. So the idea was to sensitize everyone about the dangers of steroids, even when they are used as topical steroids or even inhaled corticosteroids. The percentages may be low, but we see in our OPD sometimes patients coming with chronic fatigue, sometimes with recurrent vomiting. We don't know the reason for that, and sometimes with hyponatremia, which is not explained. So the idea was to only sensitize you about the use of some of the steroids which are highly potent, particularly clobetasol and betamethasone. And when we tell our patient, when we prescribe these things, we must tell them the duration of using steroid. But in our country, like you saw in the pharmacy sales and all, patients do not always follow our advice. My father got better with this cream, so I started using it. Or somebody else suggested this cream. Often the prescription is not from a medical professional. So that is also something we should keep in mind. So if there are any burning questions, we can take them.
Thank you, Shone and Anu, for that fantastic presentation. My question is about my patients who are with inflammatory bowel disease. We put them on Azuran, but on and off we need to get them onto prednisolone as well. So I thought you said you can give it only for 4 weeks. Is that right? Beyond that, it's a problem? No.
Yes, sir. Beyond that, it can lead to hypothalamo-pituitary
So
adrenal
4 weeks
axis.
is all that is safe.
So we can continue to give that, but we must keep in mind that these patients, if we stop it abruptly, some of them might require it for years, but when we stop it abruptly, there is a possibility that the patient could go into crisis. So when we decide to stop, we should warn the patient about the symptoms and maybe call them back to do an 8 AM cortisol. Now we don't require the complicated synactin test, just do an 8 AM cortisol. If it is less than 5 microgram per DL, or in our lab it is nanogram per ml. So if it is less than 50 nanogram per ml, then we know that the adrenals are still suppressed. So we need to keep them on a small dose and allow them to taper till the adrenals completely recover.
Thank you. was wondering whether you could write a general article in Arogyam or something about the topical use, because this is something that nobody knows that it is a problem. Thank you. Thank you
Thank you,
both
sir.
very much.
Ma'am, if the patient is already on 5 mg of prednisolone, for like sir said, for IBD we kind of taper it from 40, 35 towards 5, and by the time we kind of taper from 5, it's already 4 weeks and all that. So how do we do it?
So
When do we do the
yeah, I
8
understood the question. So somebody who is on a short course, like for an acute exacerbation of bronchial asthma given for 1 week or 2 weeks, that doesn't matter at all. They will recover. But in case your patient, some patients on potent steroids like betamethasone and all that, some of them may not require. You saw the percentage. It's only 6 to 7% of the patients on topical and inhaled steroids. But such patients, sometimes we don't have a high index of suspicion. We should, we will be doing a whole lot of investigations but not doing a ATM cortisol. Is it the suppressed adrenal that is resulting in this fatigue and hyponatremia? That is all. 95% of the patients may not have any problem. But this small percentage we should be aware of. Because a patient who is on steroids and suddenly we tapered, and they might have other comorbidities. They might have a hypotension, and during that hypotensive period, the critical cardiac block might result in an MI or in a stroke, because we are dealing with patients with multiple comorbidities, particularly the elderly, the vulnerable population. We should give them maybe tell them that if you have symptoms like this, please come back. That's all.
Thank you, ma'am. Congratulations, Shone, for this wonderful quest.
Can I make a request to all our physicians whose patients are on steroids? Having listened to this, I think we have to do something about it. Is it possible for us either to send the patients for evaluation or at least get that 8 a.m. Test done and try to taper off as quickly as possible? I'm saying this because a lady came to me the other day, and none of you were involved, but she was all bloated up. So what had happened was there was some tingling and all that, and thinking that it is some inflammatory condition, somebody prescribed steroids, and she's been taking that for 3 long years, and that's the kind of story that you said. So can we be people who will try and correct this? But we'll have to work hard on that, because I think we'll have to team up with you so that we don't suddenly stop and create problems.
We have had patients who were using dexamethasone eye drops. We will never think that there will be systemic absorption, but these are all rare things, but we should be aware of all these. Steroid in any form given in any area are capable of causing adrenal suppression.
I just want to make a couple of comments. First thing is I want to congratulate Shone and Anulekha for crafting that presentation beautifully. I had gone to Vellore for a conference recently, and Dr. Gordon Thomas, who's a pediatric surgeon, was saying, Philip, it's no longer about just doing a PowerPoint, reading it. Nowadays, effective PowerPoints are those who can provide infotainment. That's a new word I learned. Not just information, but entertainment. And I think he beautifully married some beautiful film strips, and he infotained us. So we learned something, also we were kept entertained. So it's an important clue for those of you who are doing PPTs, not just reading out things, but to also provide an element of entertainment. So the crowd, nobody slept, I think, during the presentation. That's the first comment. The second comment I want to say is, I actually did a few in-depth interviews with Dr. Devi Priya in pulmonology and Dr. Megha in dermatology here about the problem, just as a qualitative sort of understanding of the problem. And Dr. Megha, she's here, I know, she was telling me that it's very common to see combinations of topical steroids. Nobody gives for a fungal infection only Candid. It will be always Candid B with some steroid, and that's a tendency. In fact, I discovered my mother herself, for itching, somebody gave her the steroid mist ointment. So sometimes it's at home, we don't even realize. So steroids will reduce the itching very fast. And so there's a tendency. And actually this lady who put on weight, she was been taking steroids for 1 year, the cream, and she wouldn't tell anybody. She didn't even think it is a problem. But the last few weeks, the itching in the groin area was so much, she was applying it liberally. And that's how slowly she started putting on weight. And that's how this cost weight cream came out. She didn't even think she was using a medicine, even though we were asking for exogenous sources. The second thing is about the second patient, the physician who had tiredness. He says he's been using steroid inhalers for 15, 20 years. But nobody told him that fluticasone, zero flow and all will cause problem. He was using budesonide, 800 micrograms chronically. And sometimes fluticasone is the one which is most absorbed systemically compared to budesonide or beclomethasone. And the doses of Suraflow, if you take 2 puffs BD itself, it's like 1000 microgram. It's highly lipophilic and markedly absorbed. And so we do see quite a few patients on and off who are on high dose fluticasone and salmeterol, for example, or formoterol and steroids. So don't underestimate. These people, when they suddenly fall ill, nobody will remember that they took steroids. They will land up in a casualty, and if they don't get a steroid in the time of hypotension, they could even die. They can die of an Addisonian crisis. So awareness creation was the purpose, and I think Shone and Dr. Anulekha did it so beautifully. I want to congratulate them. Thank you.
Thank you, Dr. Anulekha and Shone. As Dr. Finney has highlighted, this was a topic which needed to be discussed. I just want to look at a pediatric perspective to it also. I will modify Shone's final sentence to say when to stop. I would modify it to say and what to monitor. Because the use of long-term steroids is an inevitable evil in many specialties, pulmonology being a good example, ophthalmology another, and all specialities in one way or other would use steroids. And I would also say that the acute use of steroids, things like methylpred are life-saving. And we've seen it during the COVID era, or when there is a fulminant myocarditis, we know that it is important. So it's very important to know what to monitor. And in monitoring, especially in pediatric practice, some of the areas that we don't normally think about. We prime pregnant women with steroids if there is a concern regarding preterm labor. These steroids can influence the babies to an extent that the newborn baby could have hypertrophic cardiomyopathy. In fact, I have written a review on this. And when preterm babies are born, they're inevitably given steroids because the lungs are treated with steroids. And the result could be hypertrophic cardiomyopathy. In fact, I have reported a case in which there was a hypertrophic cardiomyopathy on day 10 in a preterm baby. We recognized it as steroid-induced, stopped the steroid. It completely disappeared. The neonatologist needed to give the steroids later, and it came back. Perhaps this happens in a small subset which is primed to develop this, but the things to monitor. Plus, when preterm babies on steroids are growing up, now they are called preterm graduates. The preterm graduates reach older childhood and adulthood. Hypertension in children. Again, preterm babies are more prone to lifestyle diseases as they grow up. Even people like Amartya Sen have written about this. When preterm babies grow up, they have a high risk of developing coronary artery disease, hypertension, lifestyle diseases. So once we are in the track of steroid, it is important to know what to monitor and in which specialty it would come. So in a long term, certainly endocrinology is the cornerstone of the monitoring, but it is more widespread. And also, now the people are aware of this to an extreme extent. My cousin, who is a well-known ophthalmologist, recently told me when she prescribed 5 days of topical steroids for a eye condition, the patient came back and said she had Googled and found that steroids do harm. How could you prescribe this to me? Maybe your bracelet is the answer. Thank you.
Thank you, sir. Sir has actually highlighted various gaps in knowledge. Some of you can actually take up research in these kind of things. The ladies who are going to preterm labor, receiving beta-methasone, do all their children have, what percentage of their children develop adrenal insufficiency? So there is so much of potential in what we discussed. And in fact, we were about to take up a study on inhaled corticosteroids. It has not reached anywhere. Dr. Abel Jason from biochemistry had started it. So we have a lot of potential for research in this particular topic.
I just request Megha to say what she said when I was talking about this in another conference. She said to tell about one particular steroid cream. And I did mention it in Calicut. You want to tell about the cream and how it's abused?
Thank you all. So I think Shone did a very extensive presentation on how we use steroids. Actually, dermatologists, our bread and butter is almost steroids. So actually people joke about the fact that you give a steroid and everything becomes better. Actually it does. It's a wonder drug. But my point here is, like sir said, topicals like Candid B, it's very misused. If you look at our patients who come to OPD, you take 5 patients, maybe 2 of them would have already been using Candid B. And that would have been given by a physician, gynecologist, somebody. I'm not specifying a particular specialty, but then they start using it and then they continue to use it without knowing why they are using it. And like ma'am said, they inevitably give it to their family members, cousins, friends. So it just keeps going on and on. So my one takeaway point here would be, please don't give a steroid if you don't know why you are giving it. Also, if you're giving a steroid, tell them that this is a steroid. Like sir said, most people are well aware of steroids now. They Google and come to you. So it's a good drug, but you need to use it only for a specific period. So if you don't know why you're giving it, don't give it. Always refer to a dermatologist if you're suspecting a skin condition. Because things like tinea gets modified when you give steroids. So it's a big concern for us. People who keep using steroids for a long time, we don't even identify that there was a tinea there. So that is something that I would like to say. Things like Betnovate G, Betnovate GM, Candid B, Quadriderm, Coswate GM. Also, like Shone said in his presentation, we give it for whitening creams. So melasma is a very common thing that women have. So there are combinations where steroids are there. Now, if you tell them use it for only 2 months, it actually gives you a good effect there. But if they keep using it beyond that, they actually end up with having steroid-induced damage on the skin. So then we have to treat that also. So my takeaway here is, please don't give a steroid if you don't know why you're giving it. Refer to us. Thank you.
Thank you, Dr. Mekha. Is there anyone else who wants to ask something?
Erythrometer is used in the this Ayurveda, no?
So
You have any studies regarding that?
Erythrometer, does it contain steroid? I thought it was potassium chloride. No.
I heard about this contained steroids. You just
We can
go through
ask
that.
our...
Licorice inhibits the 11-beta hydroxysteroid dehydrogenase. So the mineralocorticoid pathway is inhibited. It's not the adrenal suppression. So it can produce hypertension, hyponatremia, all those things, hypokalemia, everything. Yeah. So it acts more like a mineralocorticoid overactivity.
Thank you.
So thank you. By hearing the side effect, you may be hesitant to start steroid, but you should avoid the steroidophobia. If the patient is really indicated, you have to definitely start steroid with the close monitoring. But by hearing the side effect, you should not abruptly stop the steroid. That's why
Yes, sir. Many of our patients, even when they require it for chronic bronchial asthma, some of them, just because it is steroid, they might not even use it regularly. So that is also a problem. So it is like a double-edged sword. It is just that we need to continue to educate the public and our patients. So it is very important to know when to stop and what to monitor when we stop. So I'm really glad that Shone took up this challenge. I'm actually happy for the discussion. That is what really makes our institution an academic institution. Thank you. Over to Dr. Abel.
Thank you, Dr. Shone and Dr. Anulekha ma'am, for that very informative and entertaining presentation. Join us as we welcome the newest members of our family, a family of hope and healing. Please come forward as Dr. Pavitra Padmakumar from Department of Microbiology. She has done her post-graduation from Pushpagiri Institute of Medical Science and Research Center. Dr. Shankari Raju from the Department of General Surgery. She has done her post-graduation from Sri Uttradam Tirunal Hospital, Trivandrum. Dr. Arvindar, who's a senior resident in critical care. He has done his MBBS from Government Medical College, Trivandrum, and MD from Benares Hindu University, Varanasi. Welcome. Dr. Nikita Shelton, Department of Biochemistry. She has done her MD from TD Medical College, Alappuzha. Dr. Colin Baby from Department of Pharmacology. He has done his MD from Christian Medical College, Vellore. Dr. Asha Monica Jose joined in the Department of General Medicine. She has done her post-graduation from Bangalore Baptist Hospital. Inviting Dr. George sir.
It's, when new people join us, it's like childbirth for us. The excitement, and so you can tell us all the good and the bad. Hope you have a great time with us. Welcome. Good to have you with us. Thank you.
Thank you. Welcome. So see you all for the next quest next Thursday, 8 a.m. Thank you.